JAMA, I am critical care fellows. And, you know, in the end of February, you may have received JAMA in your mailbox, and in that was a special issue involving critical care. Particularly, there were 3 articles that kind of built upon each other, looking to evaluate the definition of sepsis, evaluate the definition of septic shock, and then to come up with consensus guidelines about how we define these terms. So I want to go through this and these articles, and since there's 3 articles, I'm going to kind of go through them rather quickly. There's going to be some details that may be left out. Please feel free to ask questions as we go through this and discuss it. How I'd like to do it initially is to examine the Sepsis 3 studies, understand the statistical concept of area under the receiver-operator characteristic curve, and the reason I want to discuss that is because that kind of is was used in order to determine a lot of the outcomes of the study. And then hopefully we'll have this followed up with a pretty robust discussion about our thoughts for this study. Before we jump into the discussion of the new definition and how this sepsis has been thought, I wanted to just step back and look at the old sepsis or the current sepsis definition, just so we know where we're coming from. So previously, in both 1991 and 2001, sepsis was divided into 3 categories, which we're all very familiar with. I don't think you need to review this. But SIRS criteria, and then sepsis was 2 or more SIRS. Severe sepsis was organ dysfunction associated with this, and then septic shock was hypotension despite adequate fluid resuscitation, and then patients that are on pressors because they're hypotension. Now, the proposed new definition is that sepsis be considered a life-threatening organ dysfunction that's caused by a dysregulated host response. And the clinical criteria for that would be suspected infection and then an acute increase in your SOFA points by 2. This would throw out the idea of like the severe sepsis category that we have. And then you have septic shock, which they're defining as vasopressor needed to maintain MAP above 65, a lactate greater than 2, despite adequate fluid resuscitation. So the question is, where did some of these things come from? How is the SOFA score initially involved? What are we looking at in regards to our new criteria? And so the first 2 studies, one was looking at how do we assess criteria for sepsis, and then the next one was how do we define septic shock. So 2 different studies, one just focused on sepsis, one focused on septic shock. The main difference that we can see right now, just from a cursory overview, was that Sepsis 1 and 2 studies said sepsis is a suspected infection plus SIRS. Now we're using sepsis as a suspected infection plus a SOFA greater than 2. And is this something that we should use? We're going to evaluate that. So why did they do these studies? Because you look at it and you're like, did we really need a study to redefine sepsis? Like, don't we already know what it is? The SCCM and European societies decided that, we don't think we have a really good definition of what sepsis is. Maybe we could be better at having clinical criteria to say, aha, this is sepsis. They wanted to do this study to evaluate, do the criteria that we're currently using, is it actually valid? And I think part of the reason that they want to do this is because the definition of sepsis is, in their opinion, rather vague. So you have an infection and you have this inflammatory response, but you also may have a mixed response, or maybe you have a counter-inflammatory response. So are we actually getting a correct group of patients when we're defining them as sepsis just using SIRS? So how they did this first study is that they had a retrospective cohort of adult patients, primarily through the UPMC system that were gathered from 2010 to 2012. And all of these adults had a suspected infection. And what they meant by a suspected infection is that you gave them antibiotics and got cultures within 24 hours, or you got cultures and then they got antibiotics within 72 hours. So those were how they categorized a suspected infection. And then In addition to that, they followed to determine whether or not these patients, actually were infected or not. But they never really come up to that in the study, so we're not going to really focus on that. They also had 4 external data sets, which were from health systems around the United States, as well as alerts, which was actually like one subset of the population in Germany. This was all done in a retrospective fashion. They did a random split of the sample, but only of the sample from UPMC. So in order to derive their clinical criteria, they looked at half of the UPMC cohort and then validated it with half of the UPMC cohort. And then near the end, they're like, oh, we should look at these other groups too. So you'll hear a lot more about the UPMC cohort or read a lot more about the UPMC cohort as you go through this study. So the potential clinical criteria that they looked to evaluate if this was associated with outcomes were SIRS, which we've already been using for sepsis identification, SOFA score, which I think most of you are familiar with, which is a predictor of mortality. It's a sequential organ failure assessment score. They also did the LODS, which I'm going to show you here shortly what each of those includes, which is the logistic organ dysfunction score. And then you'll see here on this next slide here that they also listed criteria under what is called the Q-SOFA, and we're going to come up with that in a moment. So looking at the existing information, they wanted to see, do any of these scores predict mortality? So can I select out criteria that are going to be more associated with mortality than not? And they're basing this on an assumption that patients with sepsis have a very high mortality rate. So if I'm seeing death with these criteria, then these patients must then have sepsis. So again, they looked at SIRS, which we're seeing here. We all know them, your respiratory rate, your white blood cell count, your heart rate, all of those things that we look for. Your SOFA score, which is documented here, and then the LODS score. They ended up taking out the last 3 portions of the LODS score, the urine output, serum urea, and prothrombin time, which I don't know how you can just take points out of a score, but they took those out of the score and really only evaluated the top portion of the LODS. And then based on a multiple logistic regression analysis, they developed this Q-SOFA. So the Q-SOFA basically looked at the patients that had a large amount of mortality and said, of all of these criteria, what are the top 3 that lead to the highest mortality? And those criteria were determined to be a GCS less than 13, and I put 13-ish because they didn't really have a way to determine if their GCS was less than 13. It was any altered mental status, so technically it was probably a GCS less than 15. The tachypnea and systolic blood pressure less than 100. So then what they did next is that they said, of these ICU encounters that we have, of these non-ICU encounters that we have, how often are we seeing these criteria present? So in order for me to use them as a predictive value, I have to see, how present are they in my population. So on this graph, what you'll see here is on the A is looking at SIRS criteria, B is looking at SOFA, and then the next slide I throw up will be C and D, which is looking at LODS and the Q-SOFA. And along the y-axis, we have the percentage of encounters. Along the x-axis, we have how many criteria were present in each patient. So the right side of the screen, right side of the screen for you guys will be ICU encounters. Left side of the screen will be non-ICU encounters. And so basically what they saw was that a significant number of the population had SIRS criteria that were greater than 2. Or 2 or greater, particularly in the ICU. A lot of patients that were not in the ICU that were suspected to have infection had less than 2 SIRS criteria. Then you can continue to kind of just view these graphs pictographically and see what SOFA scores were present over the time in the ICU and not in the ICU. And then again, looking at the LODS score as box C, and then box D, the lowest one, as the Q-SOFA score. Amongst this, what they found was that, among the ICU patients, 88% of them had 2 or more LODS, 91% of them had 2 or more SOFA points, 84% of them had 2 or more SIRS criteria at the time of infection. And what they wanted to ask were, you know, how sensitive and specific are these predictors in the setting of mortality? And you have to make it very clear that they're looking at mortality. They're not saying, does this patient have sepsis or not? They're saying, does this patient die when they have these criteria? So that's a very important thing to understand when we're looking at this study. So in order to determine that, you know, they said, well, we are assuming that if we look at a SIRS greater than 2, why don't we just pick greater than 2 for these other criteria, mainly because it's easy when you don't have to look at multiple variables. So we'll look at other scores greater than 2 and see if they're suggestive of end organ damage, and compute that by looking at the area under the curve for prediction of mortality. So I just want to take a quick second and talk about the area under a receiver-operator curve, because this is a journal club, so we should learn how to interpret some data. So when we're looking at the receiver-operator characteristic, this receiver-operator characteristic is a way to kind of balance sensitivity and specificity. So on your y-axis, you'll see sensitivity. I made this on Paint, which I haven't used since I was probably like 10. But you'll see your sensitivity on the y-axis. And then this will be your rate of true positives. And then you plot that against your 1 minus your specificity, which is 1 minus the false positive rate. So you're looking at your true positives over 1 minus your false positives. And basically it allows you to determine, is this data association random or is it better than random? So what it helps you do is determine, is my test diagnostically accurate? And it also will compare the performance of one test looking at the same variable to another test. When you look at area under the receiver-operator curve, there's kind of general consensus that anything that's 0.6 to 0.7 is poor, adequate is 0.7 to 0.8, good, again, 0.8 to 0.9, and then, you know, ideally you'd be 1 is the most accurate because it would be extremely sensitive and specific. So they took all of those criteria, the SIRS, the SOFA, the LODS, the Q-SOFA, and plotted their area under the curve looking at prediction of mortality. And this table is a little bit confusing, and I didn't make my own table to reiterate it only because I think that we should talk about what's there. In the blue boxes, what you'll see is the area under the curve for prediction of mortality. This is the ICU group, and the group that's a non-ICU encounter. So the blue kind of diagonal boxes that are coming through are area under the curve for prediction of mortality. The non-ICU encounters, the blue means the same. Now on this lower portion, kind of these mauve or tan boxes that have the p-values in them comparing SIRS versus SOFA. So this p-value here is how does SIRS test up against SOFA from, you know, who's more predictive of value. And then the boxes that are kind of in the lighter beige color have to do with this like Cronbach alpha, which we're not going to talk about because it doesn't really matter for the purpose of interpreting this study. What they found was that the area under the curve for predicting mortality in SIRS is 0.64 for patients that are in the ICU. For SOFA, it's 0.74. For LODS, it's 0.75. And then for Q-SOFA, it's 0.66. So if we go back to our area under the receiver-operator curve, that 0.64 and 0.66 both fall under that poor category. And the SOFA score comes under the adequate category of the 0.74 to 0.75. When we look outside the ICU and look at patients on the ward or in the emergency department, the value of all of those, or the predictive mortality ability of all of those, goes up. So the SIRS, 0.76, SOFA, 0.79, you can read down the line. Q-SOFA is 0.81. So what this table is trying to iterate is that in the setting of the ICU, the Q-SOFA is not really useful for picking up patients and maybe not as useful for determining sepsis, but if you're outside of the ICU, it's a pretty good predictor of mortality. when you're looking at SOFA, or when you're looking inside the ICU, maybe we should be using something like SOFA or LODS to determine mortality. The problem well, we'll discuss that later, because I don't want to get ahead of myself. So what we can really say when we interpret this graph from this study is that in ICU patients, a SOFA greater than 2 is associated with an increased mortality compared to a SOFA less than 2. A SOFA is more accurate in predicting mortality than SIRS or QSOFA. Outside the ICU, what we can say is that QSOFA greater than 2 is associated with increased mortality compared to patients with QSOFA less than 2. And QSOFA is more accurate in predicting mortality than SOFA and SIRS. Which basically, in summary, means the sicker you are, the more likely you are to die, which I think we all can understand. The more organ dysfunction you have, the more likely you are to die. So some of you may be asking, well, what about lactate? Did they look at lactate in these patients? You know, we have all these criteria of SIRS, SOFA, but we know that an increased lactate portends a poor prognosis. They did do a post hoc analysis. It didn't initially meet their initial statistical thresholds for inclusion because only 9% of the population at UPMC actually had lactates drawn when they were being evaluated for suspected infection. So what they did find when they looked at the KPNC data, because about 57% of those patients had lactates drawn, that addition of the lactate level changes the area under the curve when you're looking at QSOFA. So they didn't compare it with SIRS, they didn't compare it with the SOFA score, they just looked, if I add a lactate to my QSOFA, does that increase my prediction of mortality? And logically we would say of course it would, because we know that a higher lactate increases your mortality to begin with. The only major difference was that the area under the curve went from 0.79 with the QSOFA to add a lactate, and now it's 0.8. So they basically considered that the clinical relevance was fairly small. However, the p-value was 0.001, which is what they've been looking at, which is the difference between the SIRS and the QSOFA is only 0.2 areas under the curve. So not a huge difference in what we're seeing in regards to change in area under the curve, which is why it wasn't brought up or included as far as a definition of sepsis. So now that we've completed the definition of sepsis, we're going to just briefly talk about the definition of septic shock and then the consensus definition, and then we'll have our discussion. So briefly, looking at the new definition of criteria for septic shock, this was a study that had 4 studies in it, which I was really glad that I selected this group of studies to discuss, because not only do I get to do 3 papers, but I get to look at a bunch of studies within a paper. But they did a systematic review and meta-analysis. They also did a Delphi study. They did a cohort study, and then they did some testing to see if their criteria was actually applicable. The first 2 studies I'm going to summarize, and the fact that the systematic review and meta-analysis revealed that among patients considered to have septic shock, all of the papers that they found had significant heterogeneity in the mortality. However, the overall mortality was around 46.5%. And Dr. Rivers so interestingly pointed out to me that that was the exact mortality that was quoted in the early goal-directed therapy trial, which I thought was funny that it turned out to be the exact mortality. Anyway, they noticed that there was significant heterogeneity in the mortality. And so they said, well, it has to be due to these definitions. So if the definition was the same, do these populations' mortality look the same? So then they divided it out into each separate population, and they said, you know what, even amongst the population that has the same definition for septic shock, the mortality difference is significant, or the heterogeneity is significant. So they didn't really draw a whole lot of conclusions from that, other than sepsis has a high mortality, which we all know. So then they did a Delphi study, which is basically send out questionnaires to a bunch of people that have some knowledge in the way of septic shock, and have a vote and see who thinks what is the best definition. So they could divide these cohorts, or they could establish groups and then do their cohort study. So the most important portion of this study, I think, that we need to look at is this cohort study. So they divided the surviving sepsis campaign patients into 6 cohorts. They looked at the 6 different groups based on the presence of hypotension, vasopressors, and lactate. So group 1 clearly had all 3. Group 2 had no lactate. Group 3 didn't have vasopressors. And you can continue to read how these groups were divided up. What they found was that mortality was the highest in group 1, group 2, and group 4. And I put those percentages up for you. And group 1 had the highest odds ratio for mortality. So they basically said, well, if group 1 has the highest odds ratio for mortality, then group 1 is septic shock. So being that, we need to have hypotension, we need to have vasopressors on board, and we need to have a lactate greater than 2 to say somebody is in septic shock. And mind you, well, there's no lactate that's required, despite the fact that group 2 has still a 30% mortality. So then, why the lactate cutoff? So, previously we've all been using a lactate of 4. Why all of a sudden it is a lactate of 2? So they looked at serum lactate and basically looked at the odds ratio of hospital mortality and saw that once you have a lactate elevation 2 or greater, that your odds ratio goes to 1.4 once your lactate's greater than 2. So they said, well, if my odds ratio of in-hospital mortality with a lactate of 2 is 1.4, then it's highly sensitive for in-hospital mortality, so it goes in the definition. So the changes then become that septic shock is defined as vasopressor dependent hypotension and an elevation in your lactate. The lactate cutoff is no longer 4, it's now considered to be 2. So how do we apply this? The third paper that was in the end of this journal was, let's put all these together. And so what they said was, this is our definition. Sepsis is life-threatening organ dysfunction because my host response is dysregulated. Organ dysfunction is then defined as SOFA change greater than 2. QSOFA can promptly identify patients with suspected infection who are likely to have a prolonged ICU stay or die in the hospital. And septic shock is a subset of sepsis with circulatory and metabolic abnormalities that cause significant mortality, and the criteria, as I mentioned, are listed below. And they suggest that you apply this information in the following kind of algorithm. So I think the patient has an infection, I go to their bedside, I say, aha, their QSOFA is positive. Do I still think they have sepsis? Yes, I do. So let's do a SOFA score on them. Then you do a SOFA score, and you say that they have sepsis if their SOFA score is greater than 2. Then you start giving them some fluids, and if they don't respond to your fluids and they end up on pressors with a lactate elevation, then you can call them septic shock. So that was a very quick and probably fast review of these 3 articles. There is plenty more in these articles and limitations of these articles, but I think that rather than me going through the limitations of these articles, we should just open the floor up for discussion, and I can kind of prompt some things or moderate some things as we go along. So what are your thoughts, what are your concerns, and what questions do you have about this article? Go ahead, Niraj.
How do you do the score?
Say it again?
How do you do the actual score?
How do you do the score? So the SOFA score you can do on MD Calc or evaluate. You're saying how do you?
How do you do that score? Because I was looking at it, you have your criteria, you pick the what do you do in that category?
Oh, how did they particularly do it? So they selected the worst number within 48 hours of developing sepsis. So the onset of sepsis, so if they developed or decided that suspected infection was that I got cultures and antibiotics within 24 hours, or I got cultures and then were delivered antibiotics within 72 hours. So the onset of the infection would be at the time the first thing was done.